Well, welcome everyone. I'd like to begin by acknowledging the traditional owners of the land on which we meet today, and would also like to pay my respects to elders past, present, and emerging. Well, good afternoon, everyone, and welcome to the first FightMND Scientific Seminar for 2026. My name is Dr. Sarah Bennett, and I'm the Research Coordinator at FightMND. We hold these seminars monthly on the last Tuesday of the month, and last year heard from 10 M&D research leaders in everything from discovery research to translational and clinical trials, M&D research infrastructure, and also the latest in M&D care research space. If you missed out on any of these talks, most are now available on our YouTube channel, so you can catch up at a convenient time. Following the talk today, we are leaving plenty of time for discussion and questions. So if you would like to ask anything, please use the reaction button to raise your hand, and one of our team will enable your microphone and camera and let you know to ask your question. Alternatively, you can also type your question into the chat where our team will be monitoring and read out questions on your behalf. Please note that the chat function is only enabled if you are using the app-based version of Teams and unfortunately doesn't work if you're on the web-based version. Please make sure you introduce yourself and where you're from before asking your questions so we can all get to know each other. So now to our presentation for today. We are fortunate enough to have two speakers join us for today's seminar, joining us to discuss a collaborative project which brings together expertise in M&D care research together with work in artificial intelligence. David Berlowitz is a professor at the University of Melbourne and Austin Health and is an expert in the causes and treatments of sleep and breathing disorders in neuromuscular disease. His broad research portfolio encompasses epidemiology, sleep and respiratory physiology, imaging, clinical trials, machine learning, and implementation science. Joining David today is Dr. Anthony Stell, who is Head of Clinical Informatics at the Melbourne eResearch Group. Anthony leads a team with a strong focus on practical outputs, utilizing the latest technology trends to understand the impact on clinical trends and society as a whole. David and Anthony have been collaborating on a FightMND funded project exploring AI as a tool for optimizing non-invasive ventilation use for people living with MND. They both join us today to tell us about these exciting developments. So over to you.
Thanks very much, Sarah. Anthony and I are going to do the newsreader kind of thing, where I'll start off ahead and he'll jump in. So excuse us while we share screens back and forth a little. As I start, I'd like to acknowledge that I'm on Wurundjeri people land today and pay my respects and to Indigenous knowledge and ways of learning. And I also want to, and we've highlighted here, Anthony and I, but this is a very diverse, multi-person team that's contributing to this whole program of work. And importantly, it's across multiple institutions who all have contributed various expertise. And I apologize for the drill in the background if you can hear it. So I'm actually not going to start talking about machine learning. I'm going to talk about why we care about machine learning. And why we care about machine learning is because non-invasive ventilation in motor neurone disease is effective. It's more effective in terms of survival than Riluzole. However, everybody still needs Riluzole, but it is a standout therapy. But the thing about non-invasive ventilation, and this work from Jason Acrivo at University of Pennsylvania really nicely shows those graphs on the right there. These are Kaplan-Meier graphs, and you can see this is the time until death for people who can use their machine more versus people who report using their machine less. And what it shows is it's not just getting the machine, it's also being able to use the machine that really matters. And using a machine is tough, and it's especially tough when you've got motor neurone disease. So in Australia, data that we've got about usage, if this is 100 people living with motor neurone disease in Australia, what we know is that from our last data, which is now quite old, and we think it's better, but we don't know for sure, is that maybe only 20% of people in Australia who have motor neurone disease actually start on non-invasive ventilation. And of those, only half of them keep using it. So we've only got, a bit better than 10% perhaps of people in Australia who are using non-invasive ventilation at a level to get this survival benefit. And we should be doing better than that. So Liam Hannon, Mark Howard, who's the director of the Victorian Respiratory Support Service, and myself and Christine McDonald from Respiratory and Sleep Medicine co-supervised Liam Hannon, who's a respiratory physician who, when he did his PhD with us, did a comparison in not just people with motor neurone disease, although they were most of the people in the biggest group in the trial, of how we set up, and this is Caroline, who I notice is online, how we set up people for non-invasive ventilation. And what he tested was fundamentally whether popping them in a sleep lab after we get them up and get them going makes a difference to how effective the NIV was. So the intervention was a simple comparison trial where half of the group went into the sleep lab after a few weeks, and we adjusted their sleep study, optimized the settings, and tried to make the machine work perfectly with them. If it wasn't already great from how it had been set up on the bedside by people like Caroline. In the other group, we had a control group who went into the lab and had a sleep study, and we collected all their data, but we didn't change their settings at that time. We changed them down the track if we needed to, but we waited until the end of the intervention period. So it was about 10 weeks overall, 11 weeks for the trial overall. When we did design the study, you always pick what is your primary outcome. And we thought that the primary outcome we should be aiming for was how often you woke up from sleep, because we thought if the ventilator was doing its job properly, you were sleeping and breathing at the same time and you wouldn't be waking up all the time. And you can see here that while the intervention group had on average fewer events, fewer arousals than the control group, this difference wasn't statistically significant. There are some clear outliers in this group. There are some people who probably, who this would suggest really weren't breathing and weren't sleeping very well. But this difference, importantly, overall was not different. And neither was the difference in things like patient-reported outcomes, the severe respiratory index, side effects, how often we saw them, all those kind of things. So this is contacts with your healthcare professionals. They weren't different between the two groups. So people at some level didn't notice. But what we did find was that there was a big difference in what we call patient ventilator asynchrony. And patient ventilator asynchrony is when you for example, you try and take a breath and the machine kind of doesn't see it. The machine doesn't notice that you've tried to breathe in, and so it just keeps waiting for you, or it might even breathe out, but it doesn't do what your body, what your system is trying to tell it, I need now. And the biggest difference that we observed between intervention and control, the average difference, was in these ineffective efforts where you tried to breathe and the machine didn't see it. You can see there's a big range though, but there was a mean difference. Some people had lots and lots of these, so per hour, that's an awful lot. So 300 per hour, this is per hour of total sleep time, excuse me. Some of these are inflated by really short sleep times. What we also found though, which is probably more important, is a difference in usage. So on average, where we did the sleep study optimization, the average usage was higher in the intervention group than in the control group. But this is a graph that shows every person's baseline data and follow-up data. And what it really nicely shows, I think, is not just this average difference, but the range of differences. So even in the titration group, we had some people who stayed the same. We had more people who got better, which is why this average difference is here. But we also had some people who got worse in both groups. The dotted line is 4 hours a day of usage. So that was that magic number back at the start that in motor neurone disease is associated with an increase in overall survival. And what we found when we looked at these data again was when we looked at the motor neurone disease group alone, we had more people who, let me go back to this graph, we had more people who were initially below the magic 4 hours who ended up above, compared to, you can see here in the control group where that was a much more marginal effort. And we also had fewer people who sort of subsequently fell below the 4 hour threshold. So as you can see here, if we look in the intervention group, we had a halving of the number of people who weren't able to use it for 4 hours. Sorry, that's a bunch of double negatives. So what we've subsequently gone on to do is get an MRFF grant, which is testing whether this was just something that happened at the Austin. Was it a fluke? Are we just terrible at setting up people at the bedside? I don't think so. We think it's a real effect. But we need to test it in other places to see whether it's true. Now, we are enrolling all the way across Australia. We started this graph right at the start of, this experiment right at the start of lockdown. And so everything paused for 2 years in most of the sites. So we're behind schedule, but we're past halfway now with all of these sites enrolling. And importantly, we've also got grant from a granting body with collaborators at Sick Kids in Toronto and have extended the trial across to Canada. So Canada is now enrolling into this study as well and really ramping up. So we will get the trial finished, I'm confident, although only probably confident. So we will get a definitive answer about whether a sleep study helps you to use your ventilator more when you have motor neurone disease. In a couple of years, we will know that. But we then have a problem with what to do with that knowledge, which we anticipated and is why we're doing this work and why we're collaborating so heavily with engineering and computing at Melbourne Uni, is because if it turns out that popping you back in a lab to make your ventilator and you talk to each other beautifully is a good thing, how on earth are we going to do that to the people who've got much better things to do with their life with motor neurone disease than pop back to the lab every now and then? And when we say lab, we're talking about a highly specialised lab, predominantly in the capital cities. So this is not a scalable model. This is not a good solution. This is not person-focused. We could potentially go out and run studies in people's homes, and we're doing some preliminary work looking at that now and titrate the ventilator remotely. But again, that's not going to scale quick. What's much better is what we're doing with Anthony, and I'm now going to hand over to him, where we're trying to develop a machine learning model that in the first pass will be able to detect and classify those events much more automatically and then inform the clinical care team, and they can make changes remotely to ventilators. As I said, it's a collaboration, and I'm going to stop sharing now, and Anthony's going to take over and talk about where we're up to with this work. And then, of course, there'll be plenty of time for questions. So I'm going to stop and go on mute, and it's all yours, buddy.
And I'm going to start sharing. Hopefully you can see a slide that says PVA types. Perfect. Thanks so much, David. So yeah, I have worked with David for many years now. Our team is a small group of software engineers that connect people, clinicians like David and his group, to data scientists who are also another group at the University of Melbourne. And just now what I'll do is I'll go into kind of the fine-grained detail of what it is we're actually trying to pick out from a computing and informational point of view. So of those PVA types that David just described, we've got two readouts here picking out those two different types. On both of these charts, we have the thoracic and abdominal band efforts. We've got a third line here that measures the sum of those two. The next four are pressure, flow, leak, and triggers, which are performance indicators of the ventilator. And then down the bottom here, these square-looking blocky things are the bits of interest, the bit that our machine learning algorithm is picking out. So the one along the top is where a clinician has tagged that one of these ineffective efforts has happened. The second one is a version of the algorithm doing that, saying, you know, it has also detected that there is an ineffective effort here. The three along the bottom are kind of running probabilities. So throughout the whole of a person's sleep, there's a constant indication by the algorithm to say, has an ineffective effort happened? Has a double trigger happened? Or is it normal? And putting that into quotes is one of the big challenges that we face because everybody's breathing pattern is quite unique. And part of this project has been the discovery of how unique it actually is. It can certainly be considered a signature of a person's, like, biosignatures, basically. So when we look for the proverbial needle in the haystack, what David alluded to earlier at the top of the slides was that an ineffective effort is when you try and take a breath and the ventilator doesn't catch that. It doesn't realize that that's what you're doing, and it just sort of waits. So you have to go again and go harder. And what that looks like in this pattern is this little bump here that sort of says, you know, went for a half, then went for a full, and then there's another one there. These tiny little patterns are what you see throughout an enormous amount of data. And on the right, we've got double triggers, which in layman's terms, I'm a software engineer, so maybe it's good that I sort of have to describe these as I see them in layman's terms, which is where the pressure has gone twice. So the ventilator has given you 2 breaths, but you've only taken 1, kind of the inverse of what is happening here. So this scoring goes along the bottom and tries to pick out. So in a manual effort where a clinician, it's incredibly labor intensive from a very highly skilled, experienced clinicians that need to look through all this data. And, you know, it's just not efficient. But then the machine learning has to go through and tag these as well. And something that we should also know is that when the machine learning algorithm does its scoring, the original clinician scoring is not available to it. So it's just trying to detect these patterns itself based on the training that we've given to them. So that is kind of how we go through this and try and check that what the machine is picking out agrees with what the clinician is picking out as well. So the demographics of this data set that we used, so we've actually done 2 sets of data. There was the original that David described in the original PhD work. And since then, for the 3TLA study, we've kind of gone back and tried to refine and make everything more shipshape. And throughout this, the demographics that we've used were, for the second set, a curated selection of 30 studies. Of those 30, 20 were used in a training data set and 10 were used for validation. So that's where you do a 2/3, 1/3 split of everything that you have, and you say to the algorithm, go and train on this, and then for the last third, let's see how well you do, and let's compare that to the clinician scoring. of these 30 studies, they provided a total of just over 9,000 PVA events, and roughly that was split 2/3, 1/3, with 6,000 in the training and 3,000 in the validation. And there's quite an even distribution in the average number of PVA events across sex, age, and BMI between the two data sets. Now, these pie charts, because there's no single ground truth, so there's no objective truth in this, there is a highly experienced and highly skilled clinicians, but clinicians are human, maybe they make mistakes, maybe they miss something. So what we're looking for is actually concordance, agreement, to see what the clinician said and what the machine said, and how much that agreement is in overlap. The pie chart on the left, the blue section are the amount of events in the data set that we found that the clinician scored only. So they looked at it and said, that's PVA, but the algorithm didn't when it came to it. The inverse of that is the orange bit of this pie chart, 5% on the left for ineffective effort. The algorithm went through it and said, yes, I think that's an event, and the clinician did not. And then the green one is agreement. That's where both clinician and model agreed. Now, as you can see, the agreement on ineffective effort is much higher than the one for double trigger. And we think that this is because in the training data sets, there were many more ineffective efforts. And another sort of point to make is that we're not looking for perfection here. As I say, we're looking for kind of maximal agreement, but not 100%, because we think this will develop and ground truth does not exist in kind of objective reality. But what we want is to know that for most of the time, the algorithm is picking out what we agree as a definition of PVA, which is something quite still in flux in a certain way. What we have here with these bar charts for both types of PVA events is kind of the improvement in the algorithm, the machine learning algorithm performance. And in software engineering, I'm a software engineer, and this is kind of how I approach it. There is a bit of a saying that you build the thing first, build it one time, and then throw it away. Because the building of the first thing is where you make all the mistakes, you sort of make your errors, you get it kind of 50% right, and then you realize, oh, all the things that I could have done better the second time I did it. And that is quite clearly exemplified here with the red bar chart was the first set of data that we got. And what we have along the bottom here are metrics called recall, precision, and the F1 score, which are machine learning jargon for how accurate the model is. So F1 score is a measure of how closely 50%, 0.5 is that you're 50% correct that this was accurately identified. And recall and precision are of all the relevant data that's there, what was retrieved, of all the retrieved data, what is relevant. So the higher these scores are, the better. And again, you can see the performance for ineffective effort is higher than double trigger. But the main thing to note is that the second time around that we did this, the results were much, much more improved. And that's quite important and quite promising, and it shows we're on the path to doing very well. But again, it's not maximal that you want. You just want it to be able to catch 90% of these things to say it's good enough, that kind of thing. So this sort of takes me on to a kind of wider discussion about artificial intelligence, because this is kind of what I noticed when I talk about this and people ask, what is the future of AI and how does it impact, and you're working on this, so what do you think is going to happen? Everybody's quite worried about it taking our jobs and our livelihood, etc. And in this context, I would say that there was kind of a breakthrough moment in the end of the 2010s when the processing power available to us was able to power all the clever things that artificial intelligence runs on, all the sort of neural networks and smart algorithms that do all this stuff. And in 2022, it sort of broke into the mainstream because ChatGPT put a kind of clear interface on this, and suddenly all the stuff that artificial intelligence was doing was, you know, it was machines and robots, but they were acting like humans. Now, everything we've described up to this point is basically the robots doing robotic stuff, just identifying and classifying. But the 4 key points that artificial intelligence tries to bring to bear and to improve performance in every endeavor, every field of research, or every bit of your life is speed, scale, scope, and sophistication. How fast, how big, what it can do, and how well it can do it. And what was shown here is the speed and the scale. And that's the point that I want to emphasize. It is a needle in a haystack, these tiny little patterns that are in reams and reams of data. We're looking at possibly a second or 2. No, if it's a breathing time scale, it's more than that, but a few seconds of, you know, an 8-hour sleep readout. And the overall point was labor saving at the beginning. It was, you know, the use of clinicians' time, highly skilled clinicians' time. This can be sped up. So speed and scale of artificial intelligence is what we're bringing to bear here, and what we're kicking goals and succeeding with quite well, I think. But then the open questions that I tend to throw out are, can we go further? Can we do the other 2? Scope, can it find something else? Can we look for similar patterns in general respiratory conditions? I know we've talked internally about addressing things like COPD. And the unusual bit that we are, from an informatics point of view, as I said, is the breathing signature, which is becoming clear as a unique biosignature of people. And then sophistication, which I sort of referred to as well when we talked about the concordance. Like, can it do better than the highly skilled clinicians? Can it find something that they didn't? And possibly a lot of this also depends on the definitions that we use for PVA types, which are in flux and are more or less numerous than possibly current literature says. But then a discussion that we've taken even further is when it finds a PVA. So far the speed and scale bit is a robot being a robot. But if the robot then, you know, talks to you like a human, can it recommend an action? And then possibly could it take that action to, in this case, changing the settings on the ventilator and executing it. Now, this opens up all sorts of ethical and philosophical discussions, but that's just kind of the future of where this work could go. One final bit that I would talk about, and this is really sort of my core part in this as a software engineer, we are getting data scientists and PhD students that are experts in machine learning, talking to David's team and the clinicians, and we sit in the middle as the engineers that are enabling one set of experts to communicate with another. And as we have developed this product, we've come in contact with a lot of discussions about the technology readiness level. And this is something that originally started life with NASA in the late 80s. And you've got little modular levels to say, you know, it kind of looks like a countdown, looks like a rocket really, or I know it's supposed to be a thermometer, but and at top, they talk about launch and operations, which is obviously the rocket lifting up. But a lot of the kind of funders and you know, investors that want to make this happen and have an impact and get useful technologies into hospitals and into the homes to help the community, they want a kind of measured step of getting there. So they use this technology readiness level thermometer. And we would say we were sort of here. We started with a prototype, which at TRL3, and the wonderful and gracious funding of funders like FightMND help us to go up that scale. And we anticipate we are relatively close to TRL5, which is to use it within the appropriate environment, which may be at home or maybe in the hospital. For sort of reference, we think that, you know, a clinical study with full regulatory approval and kite marks, and this is go time and absolutely ready to go, is up here. It would be the equivalent of TRL 7 or 8. And that is the ultimate goal of where we're going. The EU did repurpose this, and I think this is why a lot of the funders use it as a good benchmark to see where you are and how you're traveling and where you're going to. So just as I described here in terms of what we've developed, software that was an experimental proof of concept, we're going for 5, we're close to this, validated in the relevant environment. And then ultimately you want to get to the system complete and qualified up at TRL 8. So that's just the kind of software modular where we are in those general terms. This obviously could apply to any software, but it's something that we talk about a lot at our internal meetings, and it's worth communicating where we are and how far away we are from being available and ready. And that's kind of it. In summary, I would say, you know, summarize the clinical significance of what we're doing. It is a translational step forward towards automated PVA identification and correction for people living with MND. It could deliver meaningful survival and quality of life gains for a population that has limited therapeutic options, and also without too much pharmacological advances on the horizon. This is where we're going with this. And I might throw to David for a last word.
The last word is probably just thank you very much, everybody, for listening. And Min, I think you're going to lead the discussion. Is that right?
Yeah.
Thank you, everybody. Thanks,
David and Anthony. So I think what Sarah said was, if you do have a question, feel free to raise your hand that's on the top of your screen, or put a question in the chat box and we'll monitor it and we'll ask a question for you. So maybe I'll kick off because I do have several questions. What do you think that the role of the clinician would be if the machine learning platform is successful down the track?
So I think we don't know in this use case, but we do know what's happened in radiology. So in radiology, they went through a similar process. If we think about breast scans, I think it's a really good way to think about how this might play out. We don't have fewer radiologists than we had before. What we have is better informed radiologists. They're not spending their time doing piecework. You know, it's like working for a fast fashion company and producing, you know, 5-cent tops. They're taking this data that their intellectual property has gone into building and then being able to apply more value over the top of it. So I think that's what it would look like. Even the idea of translating this all the way through to some kind of auto-titrating machine that watches and optimizes, what people might not realize, but when we clinically look after somebody who needs a ventilator and we look at maybe downloads or from a sleep lab or whatever and see that somehow it's not quite right and we want to fix it, we don't try and fix it on the next breath. We try and make some sort of step back assessment of how is this overall related to how they feel, how many hours they've used it in the last month, for example, what were the numbers that looked a bit wrong, and what were the other confirmatory things we saw, and then we might make a change, and we might even institute that change not only over nights or weeks to see how we're going. So that degree of kind of sophistication we're a long way away from that now. And the PVA, based on our clinical trials, it wasn't the PVA that fixed the adherence. It's the other direction. People were able to use it more, and the biomarker that explains some of that difference is the PVA. So this is what we can see now, but we've got ideas about other elements around what constitutes good breathing and sleeping overnight that we'll try and incorporate as we go along this journey. We may have generalized artificial intelligence Tuesday after next, and all of this is redundant, but I don't think so. I think we're still very much in a machine learning space.
Yeah.
Yeah, the oversight role would never disappear, you know,
Yeah.
it would always be there.
Yeah. This is a question more around like the sleep study, the 3TLA trial, I guess. So if you do find a difference in the usage of NIV after the 3TLA trial is complete, how often do you think someone would need to go? I'm assuming by then you still like this machine learning technology wouldn't be ready. So how often do you think someone would need to go back to a sleep lab to re-optimize their sleep, the titration?
I don't know, because
Yeah.
that's not what we're testing.
Yeah.
And so what we're testing is whether one group is better than the other group. We may not have enough statistical power to look at what made you somebody who benefited from it or not, because that's obviously only in half of the group. And as we know, people living with motor neurone disease have a wide range of phenotypes of their disorder, different patterns. Some of them live in the country, which means that they've got other barriers to get into a sleep lab in the city, all those kind of things. So what I think it will do is it will mean that the monitoring we can do on people remotely will get another step more complicated and more hopefully more useful. So we'll know that if, for example, we already know if somebody's not using their machine much, because the machines have modems in them that can talk to the cloud. But without sending a flash drive out to get everything each day, we can't really interrogate what's going wrong easily with their ventilation, how to optimize it. If we could see that somebody had a lot of ineffective efforts, for example, and they're on settings that we think might mean that as they've got weaker, the machine is not seeing the start of a breath in, that might help the clinician go, okay, I'll modify the trigger sensitivity or modify the sort of timing of the breath or something like that. So all the clinicians know what to do with this sort of summary data. So that's where I think it will go. I don't think what it means is that we'll bring people back in every 3 months, because I don't think that's tolerable for the person, and it's very difficult for health systems operating at capacity, although that's not an excuse. I think it will mean that the granularity and the sophistication that the clinicians can bring to their community monitoring of people will get better.
Yeah, cool. Sarah.
Hi guys. This is not really a specific question to the project itself, but I wonder if you could just comment on how your collaboration came about and how other researchers who might be interested in utilizing skills such as that Anthony has and Anthony's team might have, how other researchers might be able to tap into that, I suppose.
So I've worked with David since 2013, I think, on a variety of projects. We have like our group, the Melbourne Research Group, it is sort of unique. We do research support of, supporting research as a group of software engineers. So if you walk into our kind of office in Melbourne, Muni, I believe it looks and feels a lot like a kind of small business that is doing, like software development.
Yeah.
And we have, like project management charts all over the place and coding sprints and all that kind of stuff. And as part of that, we do stuff like this. We go and do seminars. We write papers in a research space, but is applied. And that's, I think I wasn't originally on this project. I think it run for the collaboration gone for about a year or two, David. I'm not sure, before I joined, but I had worked, like say, on other projects that were very similar in nature. David had a design to put together a registry for spinal trauma. We had the necessary coding skills, etc., to make that into a reality. So yes, we have contact details to say, because people tend to approach us and say, we have a software problem, we have a research idea that we think, all we need is a few competent techies that can sort of turn that into usable software. And small businesses tend to cost a fortune and have bottom line ideas about creating their stuff, but we do it in a kind of research context with the University of Melbourne behind us. So that's kind of the advantage of where we sit in that space. And if people are interested, I can absolutely share our contact details on our website and all that to facilitate ideas
that
like
sounds
that.
great, because I'm sure a lot of research groups out there recognize that gap in their capabilities. And obviously that the technology is ever evolving, and so that's something that people might want to be interested in bringing in those types of skills.
They tend to try to do it themselves, actually, because people have the whole world is having to learn how to cope as technology takes over, or to cope and code. And, the people sort of will get a PhD student and say, well, they did a bit of coding, so they will try and do it. But then it falls over if it explodes and, gets really popular. And we've got the skills to kind of manage that down and say, here's how you do it properly, that kind of thing.
Thank you.
David.
Great presentation, guys. And David, I'm looking forward to coming out to Austin in a couple of weeks to say hello in person. It's probably a question for Anthony, and forgive me if I can't remember the two measures, but the algorithm, the second time round when you built it, it was a lot better at improving in the left-hand measure than it was in the right-hand measure. Why is that? I'm just really curious from a techie point of view.
Yeah, sure. We think that it was because there was simply more of those types in the training data that we had. So this is part of the interesting, frustrating sort of points of developing and testing. I'm from a kind of older school where software had a determined output, and you put something in and you get a repeatable output every time, and you could tick it off and say that works. With machine learning, statistical kind of powered stuff, and then even more so now with AI that uses large language models, it's not deterministic. You have to make a sort of good enough probability that what you put in is repeatedly getting within 95% of what you expect. So that kind of happens here. Like, we feed in 9,000 PVA events, and roughly there's a split where we think the percentage of ineffective efforts it was much higher in the training. So, show a robot 90 pictures of a dog and 10 of a cat, it's going to be much better at figuring out, where are the dogs in this data set rather than the cats. So we think that that's what's happened there. And the answer to that is to get a kind of wider pool of more heterogeneous data, like, more varied and different types. And actually, a kind of direction that I didn't mention would be to get kind of lower quality data to see, as AI and large language models get better and better, can it do more with less because the algorithms underneath are getting better and better. I firmly believe that that is happening. And like David said, probably next Tuesday we'll be able to use something new and say, "Oh, right, look, it does 110%, amazing," because the speed
And just
of
very
development.
quickly, in terms of a clinical benchmark, is it 90%, 95% that you need to for it to be rolled out as a clinical tool? Are you aiming for that 95% or something a little bit higher? What's this kind of benchmark?
I think so. David's got more context on that, I think, but
I think it's best thought of, David, and I think in terms of like a non-inferiority trial. Given that we don't have a gold standard, we have clinician assessment, which is inherently variable within and between. It's like when you bring a new drug to market in many ways, you want to hit non-inferiority, because if we were non-inferior in accuracy, but clearly superior in time, then that would advance it forward. So it doesn't have to be better. It just has to be not substantially worse. And like Anthony said, this is a situation where good enough is frequently more than better enough, if it can do it almost infinitesimally faster.
Thanks very much.
Thanks, guys. I have one last question. It's a cheeky one, but how long do you think this technology would be ready for market? Do you think it's like 3 years? Do you think it's 10 years? Or does it just depend on how fast technology changes?
Can I ask you, Min, when was the last time you heard an answer to that you believed?
Never.
I've written stuff down that says by the end of this year, so I've written it, so it needs to happen.
Look, I think these are people we're dealing with. We want to make sure we get it right. And so I think that the impact of meaningful incremental change will be soon. But we do need to be careful, and we do need to be mindful that this is not stuff we want to get wrong. So we're always going to be conservative in the way we think it matters. We've got a great advantage with the multinational trial in that we're running the experiment before we had the tech to do this. So that experiment is going to provide us with a great deal of information and around, well, first of all, does this matter? And secondly, if it does matter, can we do it well and perhaps better by using these machine learning models and the insights that Anthony and Uwe and the others in engineering and computing and information science have brought along with the long-standing expertise that's bound up in the VRSS and at the Victorian Respiratory Support Service, and all of the clinical insights that we've been able to gain over decades. So, look, the other thing for me as a working in public health and now also for a uni, for us, commercialization is not about being able to retire. Commercialization, although man, it's looking good, the retiring bit, not the income, but I think it's really about if we can't work out a way to get this into devices, we can't get it to people around the world. So we have a really, really strong clinical reason to get the commercialization piece right, because that's the only dissemination pathway. Writing 40,000 articles, getting it in Lancet, just that won't cut it until there's a commercialization, until somebody can purchase this from a vendor. We can't get it out to people, and we definitely can't get it out to people in lower and middle income countries.
I would add the AI bit of it as well, is that is obviously changing at a phenomenal rate, and so kind of what goes in to power it will change by, keep making that joke, by next Tuesday or whatever, but that will keep going. But it's the process around it that we are focusing on that is what David describes there, and the learning that comes out from this anyway, and being ready to take whatever amazing AI is available to us, plug it in, and then hand it on. is kind of what we focus on, which is an ongoing process.
Thank you, Anthony and David. We've got one comment in the chat, which is from Phil Camden, who said it's exciting work and direction, and thank you. Sarah, do you want to wrap the webinar?
Yeah, thanks so much. That was so interesting to hear about how you can work collaboratively to use technology to solve problems. That was the big takeaway from me. So yeah, just thank you for taking the time to speak with us today. If anyone would like to follow up anything with either David or Anthony, I'm sure that I'd be happy for you to reach out directly to them, or please reach out to us at FightMND if you'd like us to help you connect with them. So thank you to all the audience for attending the seminar today. We hope you've enjoyed it. Please join us again next month when we'll have a new seminar, and keep a lookout in your emails for this, which will take place on Tuesday, March 31st. Thank you again, and we'll see you next time.
Thanks you.
Thanks
Thanks,
all. Bye-bye.
guys.
Thank you so much.
Bye.
Thanks, guys.
Bye-bye.
That was really fantastic. Thanks.